Or you just get in last night?
Yeah.
I'll send out the email. Yeah. Is it going to be with me and Dan?
Yeah, you and Dan, and then it's usually Aaron. Well, it's usually all of those. And I don't know if Dave,
Okay.
right?
Just
Matt has to come. I mean, you're kind of in there like postdoc.
Okay.
Yeah, whatever. I think we won't have that class. I'll just have you and you guys come here.
Have you met?
If you disappointed people, that's okay. Just have to win them over. Yeah. Nice meeting you.
Well, I have a hard time.
Hey, man.
Yes. He told me he's coming back to San Francisco. I didn't even know he was away.
I think he's hanging out here.
Yeah, the college buddy.
He's down in the area.
I think he has an old friend that every year they do some kind of trek. Last year, where they went up to Yukon. They were like, they hadn't seen anything
And then last week,
Told you.
Wow.
He answered his email. He's been off the grid for 4 days.
I used to, when he was on the Stanford fruit camp, I think they had like 3 seasonal things that used to go flying or something. So maybe somebody pretty well. Yeah, I think he's coming back to San Francisco. But our other fellows are here. And we'll get some more.
where do you live?
My dad was
What sort of night?
Dad and I are close friends. Gary is a community allergist. The parking's getting hard. This neighborhood, I don't know if you know what's going on. This whole neighborhood called South Lake Union. It used to be a lower middle class sort of somewhat light industry residential. Between Amazon and the building here and called Allergy. Allergy Gate just completely renovated. Construction. Allen's real estate company over a decade bought up most of this demolished it. Now we have young techies here by the thousands. And the whole neighborhood changed.
But there's no parking anymore.
Can we get parking underneath?
Bill's working on that.
I mean, really, just for
And what?
I know that the
be in the
construction
building.
should be
Can we
going
just be in the
on.
building and be out by 8:15? I mean, we'll be gone by 8.
Bill's working on that.
Okay, because it's ridiculous.
It is. It's tough.
I'm like 10 blocks away.
And parked between 2 signs, like, and it was like 6:25, I can't think. It was like, no parking
You
in
can get here early.
No parking wasn't here.
Because the construction workers get here like 6. It's all construction.
Yeah, right. They take all this time.
Yeah.
Where did all you people park?
Miles away.
Yeah, the construction guys. I mean, they run right in front of you and take the space, and then they get out. It's like, gosh.
You gotta get here early.
Really early.
Yeah.
I already leave at 5:20. I can't even.
You didn't block me in this week.
That's true. Somebody else blocked me for you.
Okay. And shoulder. And it's better.
Yeah.
Okay.
I'm still going to be talking to your guy, I think.
Better. Well, I need a signature here.
Okay. How come you sign twice? Are you print?
Print and sign.
From Mike too?
Yeah.
Here, Mike, before you go away, sign this. Where do you go? Amen.
Across the street that way. This is all. Yeah.
You know, Elaine, it's so sad because I see 2 more holes that they just dug in the ground, so there's 2 more going out there.
I had a patient who's like construction supervisor for the neighborhood. So a year ago, he said they're only like halfway done.
I wish we could park downstairs for the research session. We're all out of this catered it all. But
Well, apparently Drew, not Drew, was looking into it, the optimist.
yeah, that's sort of my thoughts.
Going down the past week.
How many signatures?
You're going to jail. What did I miss? You're going to jail. I want to know. No, that's the last time I think about it.
This time, okay? I was really close.
You know, like, oh my God.
Right near the subway station. I'm sorry, right where I was. Oh, yeah. Yeah, she lives like across the street, like up 2 streets across that. But then when somebody got Laura, oh yeah, we cannot get across. We have to like be giant turn around.
My husband vaccinations, I know it's really when they come back from driving places. Well, it's kind of crazy, but you know, there'll be accidents or something, and so I'll be like, I'm always like recording. But one time we were driving on Aurora, and this man in a wheelchair was like trying to cross Aurora, and then he was trying to get over the middle with a leg in his wheelchair. I mean, I'm just like, this is crazy. So of course I got and my husband's like, oh my God, they're gonna have you. I'm like, but that's not right. Like he's gonna get killed. I mean, he's like,
Oh yeah. It's a good word. No parking is the other.
Yeah, exactly.
I
Down here, this lady just randomly walked out and wasn't leaving. I was somebody actually leaving.
Work on trying to reach that.
Lucky you.
It's not only construction, obviously they're like painted the curves there, so they get parked.
You?
No, no.
He's down in California, I haven't talked to the other. Let's go ahead and get started. For those of you in our outside audience, the reason we're a couple minutes late is parking around this building, I gather, has become progressively more difficult, more and more construction here in South Lake Union, and I think it's going to go on for years still. One comment, I got some feedback last week. Everybody heard me say that working with the CME office here at the university was extremely frustrating, and I didn't know how many people claimed their CME at the end of the year, but I heard from a number of people that the CME was important to them. So this whole year is taken care of, don't worry about that. And we'll continue to do it. It's not impossible to work with the CME office, it's just unpleasant. At least the woman who runs the office and I don't see eye to eye, let's say that. I'm very happy to have Marc Riedl up here. Very
very kind of him to come up and give us a talk. He's down at UC San Diego with Bruce Zura. They and others have started what I think is the intention is to be a national referral center for complex angioedema, a very necessary asset for people in our business. You may want to say a couple of words about that and how we would refer patients down there, as well as giving us an overview of the entire condition. I asked him particularly, I'll remind him now, to make some comments about how we deal with these difficult apparent, what we used to call type 3 or C1 esterase normal angioedema. So thanks very much, Marc.
Great. Well, good morning. Thanks for the invitation to be here, and particularly thank you for inviting me before it gets really rainy. I walked over here this morning dry, so I was happy about that. I grew up in Missouri, so I'm used to all kinds of weather, but I've lived in Southern California long enough to become a complete weather wimp. So sometimes forget that it's not sunny all the time everywhere. So thanks for the kind introduction. As Dr. Altman said, I moved from UCLA to UCSD just about 2 years ago now for the express purpose of joining forces with Bruce Zura and really setting up an angioedema center, if you will, which has a number of components to it. But my clinical interest really has been in angioedema and the number of conditions that lead to that symptom. This morning we're going to talk about hereditary angioedema specifically, but I welcome any questions you might have about other types of angioedema. We are seeing a lot of complex cases referred from around the country, and we're also working actively in the lab, which is really more Bruce's forte than mine, but working on some new diagnostics to try and help us sort out these complicated patients. So here's my disclosures. I sometimes joke that I'm multiply conflicted. I've worked with pretty much everybody in the space who's developing either diagnostics or treatments for this condition, and I don't think that will influence my presentation, but if you feel it does, please say something. So we'll cover these few things in the next 45 minutes or so. We'll talk about the symptoms of HAE, which I'm sure most of you are familiar with. Just review quickly the diagnostics, including the laboratory features of these different subtypes of HAE. And then I'd really like to talk more about the evidence we have for treating HAE attacks, either in a acute or prophylactic fashion, which, as you know, are the two strategies we have to deal with this condition. So in terms of the epidemiology, here's what we know. We do know, of course, this is a genetic condition, that it's autosomal dominant, so it's passed down from generation to generation in that fashion. And the prevalence numbers you see here, the 1 in 30 to 1 in 80,000, these are really taken from European studies where they have sort of universal health care, and they can track very carefully the specific diagnoses in a population. So this is at best an educated guess, but the couple of large studies that have been done really hone in on about 1 in 50,000. And so that translates probably up to, at the max, 10,000 patients in the United States. Now that said, as you well know, this is an underdiagnosed condition, so we don't know how many patients are still out there that have not been properly diagnosed, but that's probably the ceiling around that number. There have been no clear racial differences or ethnic differences. There was a time not that long ago when people would say, well, there's no HAE in China, there's no HAE in Japan. Turns out there is. You just have to look for it. And in fact, the Chinese have one of the largest centers in the globe now in terms of the number of patients, because there's a heck of a lot of people there. The other interesting thing is as far as there are cultural differences, I think, in terms of diagnosis. And so the British Medical Journal, I think it's a couple years ago now, had a editorial about Japanese culture and how if you have a genetic condition there, it brings shame on your family. There's a huge stigma attached to this. So these patients, they did a profile of a woman. She hid her whole life. She didn't want to go to the hospital. She didn't want to be diagnosed because she knew that this was going to bring shame upon her family. So as far as diagnostic, prevalence, epidemiology, these are some of the factors that sort of come into play. Now, as you know, this is caused by a mutation in the C1 inhibitor gene. It sits on chromosome 11, and there's literally hundreds of these different mutations. So you can see here, it points out there's at least 300. There's more than that now. But these come in all different flavors: frame shift mutations, deletions, missense mutations, but they all lead to the same result, which is that the C1 inhibitor protein is either underproduced or it's dysfunctional. It's a mutated protein with an incorrect conformation, doesn't have the proper inhibitory properties. And one thing that we'll come back to, as you probably know, there are de novo mutations. So while we always take the family history when we talk about angioedema, even people with C1 inhibitor deficiency, about a quarter of the time will have no family history. They're the first lucky ones in their family to have this. So that lack of family history does not exclude the diagnosis. As you know, angioedema really as a symptom is fluid leaking out of the vasculature into the deep dermal tissue usually. This can occur in the skin, but it can also occur in the airway or the mucous membranes of the intestinal tract. And with HAE, this is a bradykinin problem. I'm sure you're familiar with this, but this has nothing to do with allergy, nothing to do with histamine. This is dysregulation of the contact system, the kallikrein-bradykinin system. And that results in the edema that we see symptomatically. Also can be very painful, particularly if it hits the intestinal tract. One of the real hallmarks of HAE is the variability, and that can be within family members. So there have been many genetic studies now tracking family members with the same mutation have widely variable clinical symptoms. So within one family, you might see someone that's having an attack every week, and they might have a child or a sibling that has an attack once a year. We don't know why that is. This is one of the things we're very interested in, or what are the cofactors that lead to the phenotype, that lead to the clinical severity. And that's also, that variability can also be true within a person. So they may have times in their life when their HAE is quite mild, and other times where it becomes very severe. And so again, not exactly certain why that happens. Many of you have seen these patients, but in case you haven't, here's just some photos of what you do see during the times that they swell. Here's a hand attack, and this is almost universal. So nearly every patient with this diagnosis will have some cutaneous swelling. This doesn't, of course, kill people, but it's very disabling. I've had many people come in that have difficulty doing their jobs, can't put your shoes on, can't walk to your college courses. So it can be incredibly disabling. And I have seen now actually 2 cases over the years of compartment syndrome developing that required fasciotomy. So this can be quite devastating in the most severe form, but that's highly unusual. Abdominal attacks. These are incredibly debilitating. This also affects about 90% of all people who have this diagnosis. So this with the skin findings are really sort of the red flags for testing. And this, as you may know, this is quite severe pain in most patients. So in a huge study in Europe, Conrad Bork Center, where they looked at thousands and thousands of abdominal attacks, asking patients to rate them on a scale of 0 to 10 for pain, that the pain was about 8.5. So this is not, my stomach's a little sore, it's really, I'm going to the hospital because I'm having such intense abdominal pain. And as you well know, unfortunately, at least historically, this has led to people having unnecessary surgery. So I have many patients that have been in the operating room, and I try to make light of it. I tell them you've just had some bits removed. You've had your appendix out, you've had your gallbladder out. Some women have had gynecologic surgery. If you pull the path on these people that have HAE, it's mostly normal. Now, the only caution I have here is that once people get diagnosed with HAE, we tend to pass everything off as abdominal pain. And I had a woman a few years ago, she had raging pancreatitis. It wasn't HAE. So you can't be fooled into thinking everything is due to angioedema. But the vast majority of the time, these people know their attacks, and that's what's responsible for their abdominal pain. So we try to keep them from the operating room when we think that's what's going on. And you can just see the CT here. This is a small bowel that's grossly edematous. And abnormal. So sometimes CT or ultrasound are helpful in picking up these signs of intestinal angioedema. This is, of course, the most feared complication, the laryngeal attacks, and this is what literally keeps me up at night sometimes with taking care of a lot of these patients. This does not happen to every patient. I guess that's the good news. Try to be optimistic. Only about half of all HAE patients will develop airway swelling during their lifetime. But of course, we can't predict who that's going to be. And so I sort of, there's this old mutual fund saying, past performance is no indicator of future returns. That's HAE. Unfortunately, every patient has to be prepared that this could happen to them, even if it's never happened before. So we'll talk a little bit about management plans, and this is an eventuality that every patient has to be prepared for, even if it doesn't occur. So you can appreciate, this is a child, actually. I think it's about an 8-year-old. And you can see this is normal, and this is during an attack. So you can appreciate the enormous swelling of the soft tissue, and this air column basically starts to cut off, which is what becomes very concerning. So this requires, historically, and still today requires airway management, but now fortunately we have some options to stop this from progressing to the point that it leads to asphyxiation. So here's the subtypes of HAE as we currently classify them. As you're quite familiar with, we have 2 types that are directly related to C1 inhibitor protein deficiency. Type 1, which is the vast majority of cases, is a reduced level of that protein. So you send a quantitative level, it's usually less than 50%. Type 2 is where the level is normal, but the liver largely is cranking out a dysfunctional protein. It has the wrong conformation, it's misfolded, and because of that, it doesn't have the proper inhibitory properties. And the importance of that is not, of course, for treatment. We treat these the same, type 1 and type 2, nor for phenotype. No one's ever been able to describe that these people look differently from a symptomatic standpoint, but it's really a diagnostic of diagnostic importance. So you really have to send the functional C1 inhibitor test in order not to miss this 15 to 20% of type 2 cases. Now the third type, we called it type 3. We didn't like that name, so we tried to, HAE with normal C1 inhibitor does not roll off the tongue, I will recognize that, but we really wanted to get away from the fact that this is very different, at least from a pathophysiologic standpoint, than type 1 and type 2. Near as we can tell, HAE with normal C1 inhibitor, as the name suggests, has nothing to do with C1 inhibitor dysfunction. And so these people, you can test their level, you can test their function, everything looks normal, their C4 is normal, and yet they have a phenotype that looks very much like type 1 and type 2 with a few nuanced differences. These tend to be women, largely, as you know, almost, it's over 90% women. It tends to have an estrogen-sensitive pattern, but that's true for type 1 and type 2 also. And it tends to affect the face, the lips, and the airway more so than the abdominal tract. So these are, again, you may not know it just by standing people next to each other, but in large studies, those are the differences that start to come out. And the real challenge, and I'm happy to answer questions as we go about this, but the real challenge with this condition is we have no good diagnostic tests to identify these people. So part of, there's been a lot of call for studying these folks. As you guys know, as physician investigators, in order to study a group, you've got to define a group. And right now, we have no good way to draw a circle around who has this condition and who has simply idiopathic bradykinin-mediated angioedema. And this is where I spend a lot of time talking with patients, because if I tell them they have this has connotations to it, right? This is a hereditary condition. This means it might affect your daughter, your son, other people in your family. And right now I have no either good genetic or mediator marker to identify what the problem is. So at the moment, we're sort of stuck with a clinical diagnosis, and some of you may have seen a paper that we published a couple of years ago now, trying to define this clinically, and to be frank, it's a pretty poor clinical diagnosis. It's basically you're resistant to high-dose antihistamines and corticosteroids, so that's trying to get at the bradykinin pathophysiology that we think underlies this. And secondly, that you either have a family history, we can come back to that, or that you have a factor 12 mutation, which has been, as you know, described in Europe. In Europe, it's about 30% of the population that they think has this. I can tell you, I've spent a lot of money on factor 12 mutations. It's a low-yield test in the United States. I've had two, but I've probably sent 50 to 60 tests. So it's not 30% in my population. Now, I'm either testing the wrong people or we're not looking for the right mutation. I'm not sure. But
it's 0 for me. I stopped sending it.
Yeah, and I think you can spend a lot of money and really not find much. But yeah.
Are bradykinin measurements accurate enough to use that in diagnosis for these conditions?
Well, so you can measure, as you suggest, you can measure bradykinin in the plasma. It's very difficult because it's highly labile. It's hard to stabilize bradykinin. And in fact, just drawing the blood through the syringe into the tube will actually falsely elevate bradykinin levels. And then it's very labile, so it goes away very rapidly. So it technically can be done, and there have been papers published by Ciccardi and Nussberger and a number of people. In fact, some of the early work in HAE demonstrated that you can measure elevated bradykinin levels, but it's technically very difficult. So we don't have a commercial assay right now to do that. And this is one of the things that Bruce is working on and Alan Kaplan's working on as well. And some other people, is we need an assay. We need an assay to say, when you see these folks, is this bradykinin or is this histamine, basically?
Are they really hereditary?
What's that?
Are they really hereditary?
Well, some of them are. So, again, if you go back to the original literature in Europe, Conrad Bork, who first described this, and there have been others, but they trace it down. They show the pedigrees. And so there's groups in France and Spain and other places that have done the same thing. That tends to be with the factor 12 mutation folks, so you can actually confirm they have the mutation and that they have symptoms. They have nice family trees. But what we're seeing, I think, is a lot of noise, is that everybody that swells that doesn't respond to antihistamines gets this label, which I don't think they all are that. I don't think they all are hereditary. So anyway, to come back to your question, we're working on that, we collectively, others. What's come out as maybe being more valuable is actually split products of high molecular weight kininogens. So not measuring bradykinin specifically, but the split products that the sort of products of bradykinin production are a little bit easier. And I say this, I don't do this personally, but a little bit easier to measure and a little bit more reliable as a marker of contact system activation. So there's hope that could give us a test that would tell us what system is underlying the swelling, but we don't have it yet. Yeah.
How about these patients that seem to respond to very high levels of antihistamine, obviously suggesting that that's, like, why don't they have hives, or any thoughts about pathophysiology, related to mast cells or something else?
Yeah, well, and so we can come back to this a little when we come back to treatment, but when I see a new patient, that's actually the first thing I still do. I put them on really high levels of high doses of antihistamines. I borrow from Kaplan's, urticaria literature, sort of four times the usual dose, and that cures a lot of people. So there's a lot of, and in fact, that's probably, if I look at all the people that come to me with this diagnosis, a lot of them will respond to 40 milligrams of cetirizine because no one's just pushed the dose high enough. So I think that's part of the sort of weeding out process, if you will, to try to get to who really has this problem.
I mean, are you studying such patients like this? The reason I ask is I have a mother and two daughters.
Yeah.
Do this all the time, and that worked.
Yeah.
The high doses.
Yeah, we want to include those patients as we're trying to build a registry. We have built a registry. It's just we got to grow it, but and we want to include those people also because that's a comparison group. What's different from those folks as opposed to these that truly have this hereditary with normal C1 inhibitor bradykinin mediated form. So back to your question. What I was going to say about the current clinical definition is, we require either this mutation, which we're not finding much at all in factor 12, at least in the United States, or a family history. And it's sort of the old story. If you torture the data long enough, it will confess, right? So if you ask people enough times, did you have a family history? Oh, yeah, I think my Aunt Mabel, once back in the 1940s had a swelling attack. Oh, well, okay, well, that... So it's not a great clinical definition. Unfortunately, until we have an assay, that's sort of what we're stuck with. So I guess the upshot of this, and we can come back to this at the end. I struggle with this. We struggle with this just like you guys are. I don't have the answer. I joke that if you want to read 3,000 words that say very little, you can read my review on this in JCI in practice because there's a lot of hand waving that goes on with this condition right now.
So clinically. What about itching and hives? I mean, if they have that, obviously histamine's involved,
yeah.
but people can have random hives at some point in their lives.
Yep.
This too, they can coexist. That confuses the issue as well.
It does, and a couple. So it's an excellent point, and a couple things on that. One is that it's rare, but I have people that have two different things going on. And they have. I'm talking now about true C1 inhibitor deficiency, but they also have urticaria, and that goes against everything we ever learned about this. But you're allowed to have two different conditions. The other one that sometimes throws a wrench in the I think the evaluation is the erythema marginatum. So, everyone in this room, if you saw erythema marginatum, you'd say, well, that's not hives. That's a serpiginous rash. It's usually not itchy, although some people will say it's a little itchy. But if you ask patients, they'll say, yeah, I break out in hives before every attack, before every swelling. And then people get off, oh, well, you have chronic urticaria. And so the erythema marginatum as a prodrome sometimes will get us off track in thinking that they have a histamine-based problem.
How about the incidence with ACE inhibitor use? Is that really a subtype of this kind of condition, where some people are more prone to the angioedema when you block the...
Yeah, so ACE-induced angioedema is almost certainly bradykinin mediated, so it does fall somewhere on this spectrum here. The pathophysiology there, of course, is that it's probably a bradykinin metabolism issue rather than a C1 inhibitor production issue. And the current thinking, although it hasn't held entirely true, but is that as you know, when you give an ACE inhibitor, you block the main pathway by which bradykinin is degraded. Everyone has, of course, different genetics, and there's all these different secondary mechanisms by which bradykinin is broken down. So in people who are genetically deficient in those secondary metabolic pathways, they're probably more predisposed to the ACE-induced angioedema. Now, that hasn't all been worked out, and there's a lot of work in aminopeptidases and different alternative pathways for bradykinin breakdown. And in fact, we have some interest in looking at that for this condition. Maybe that's why these people swell. Maybe it's not an overproduction problem, but they're accumulating too much bradykinin because some other metabolic pathway has been knocked out. So, but ACE is probably related more to that than it is anything that we're talking about here.
You can't give ACE to these people; they'll crash.
Yes, well, that's a great point Art makes. That ACE inhibitors are a bad idea because they already have production issues, and now you block the degradation. You almost inevitably get attacked. Okay, so to move along a bit on pathophysiology, just a reminder that C1 inhibitor, as you well know, has lots of functions. When I'm teaching our fellows, I sort of it's a promiscuous protein. It gets around. It interacts with lots of different pathways. For the purposes of HAE, it's really the contact pathway that's important because it's the dysregulation or the lack of inhibition of kallikrein primarily. But it does have roles in fibrinolytic system, the coagulation system, and of course the complement system, which is how it got its name. I'll show you as we go through the factor 12 and kallikrein inhibition are really the most important for stopping bradykinin or regulating bradykinin production, and it is that bradykinin which has been determined to cause swelling. So everyone has to promise not to fall asleep for the next 30 seconds, but that's always the risk of putting these together. Everywhere you see the yellow dot is where C1 inhibitor has an important inhibitory function. This is the C1 inhibition, and that's been very clearly, I think, shown not to be the swelling, not to be the reason for swelling, but it is, of course, what we use to screen, because if you don't have C1 inhibitor, you're constantly chewing up your complement 4 component, so you'll see C4 levels low almost across the board all the time in C1 inhibitor patients. Now I say almost because Mike Frank showed back in the 1970s, about 5% of these people that lack C1 inhibitor have a normal C4 if they're asymptomatic. So you can trust the C4, but not to the nth degree. It could be normal in a very small group of these people. Now, if you test them when they're swelling, it's invariably low. And so that's another tactic we use sometimes. Now I'm talking about type 1 and type 2 HAE. So the action really here is blocking kallikrein, so you stop bradykinin production. C1 inhibitor also, of course, inhibits factor 12A, which does have a role in activating prekallikrein, and also has this feedback loop. So there's this sort of snowball effect. The more factor 12A you make, the more kallikrein, but also the more factor 12 you convert to 12A. So you sort of get this snowball effect that leads to more and more kallikrein activation and more bradykinin production. And so the reason for swelling is bradykinin. The C4 level is useful for diagnostic purposes. Any questions about the pathophysiology or the general background so far? Okay. So let's talk a little bit about recognition and diagnosis quickly. How many people in the room are pediatric trained? About 50-50. So this is a pediatric condition, and this doesn't show up on the pediatric boards, I'm told. I'm not a pediatrician, but it does show up on the... I got at least one right on my medicine research boards because there was a question on HAE. But so this has been sort of an issue because this is a pediatric condition. It almost always shows up before the teenage years. Now, the symptoms may be fairly mild. They may be infrequent. And I think a lot of times it may be abdominal pain that's attributed to other things. But this is what the data shows, that it's unusual for people to show up with their first symptoms after the age of 20. These are a couple studies looking at children because we really have tried to emphasize recognition in the pediatric population. And there's a little bit of a discrepancy here. You can see this is actually quite a large study from Hungary, Henrietta Farkas's group, showing that most of these attacks actually are cutaneous in children. So if you look at foot, neck, face, the vast majority, probably 75 to 80%, are skin symptoms. This is Bill Lumry's data from an open-label extension of a C1 inhibitor trial, and in his population, some of this may have been that these were people seeking treatment, but he had a large preponderance of GI symptoms in the pediatric population. So, but this is consistent with what we know about HAE. It's usually the skin or the GI tract that's affected, and that holds true for children as well. So we know there's a problem with recognition and misdiagnosis. If you look at surveys of patients, most of them have been misdiagnosed at some point. Either you have an allergy problem, you have a gastrointestinal condition. Some of them have been told they're neurotic and they need to see a psychiatrist. But at any rate, this is overlooked most of the time in most patients, at least for a period of time. And as we've talked about, many of them end up undergoing surgical procedures. This last point about family members being tested, I have to admit I've changed my opinion about this. When I started doing this several years ago, I sort of felt like, well, if you don't have symptoms, it's probably not that big a deal. You get tested if you have a problem. And then I started attending a lot of patient meetings and hearing a lot of stories about deaths, which was the first attack in a family member. So, a teenager or a 20-year-old, they knew it ran in their family. They'd never had any real symptoms. And their first attack ended up being a severe airway attack, and the person died. So because of those stories, they're only anecdotes, but because of that, I really do encourage, if there's a known case of C1 inhibitor deficiency, that they get immediate family members tested and at least have a plan. You may never need the medicine, you may never need to go to the hospital, and that's my hope for those patients. But if you have the condition, you are at risk. And this has actually been borne out by this study by Conrad Bork now, showing that if you're undiagnosed, you have up to a 9-fold higher risk of dying from this. So he looked at, in his large group in Germany, he looked at 70 deaths due to HAE, and 63 of those patients were undiagnosed. So the vast majority of mortality due to HAE is due to undiagnosed patients. These were relatively young patients, a mean age of 40, and they lived 31 years shorter lifespan than those who had been diagnosed. So these are pretty sobering numbers, and this is part of the reason I've really sort of changed my tune. I really tell families it's a good idea to get tested. I know it's scary. I know sometimes you'd just rather not know, but it could end up saving your life, and so I think that's important for us to understand this. We talked about family history, so again, counseling parents, it's a 50-50 chance. If there's C1 inhibitor deficiency, it's autosomal dominant, so there's that chance that the child will have it regardless of their gender. And we also know that there are these de novo mutations, so the family history is not absolutely required. The last point there, which was actually, I think, I get asked about a lot, which is obvious to us, I think, autosomal dominant, but patients don't always get this. So if you don't have it, it stops there. There's no chance that your children will have this. And so that's, I think, a relief to a lot of patients to hear that. We've talked about this already, so this is just the symptoms, the skin, the GI symptoms. I will say, again, I don't have a huge pediatric treatment population, but this is, I think, a pretty common story. The kids have abdominal pain. There are literally dozens of things that can cause that in a child, and sometimes I think it's overlooked. So it's sort of this recurrent pattern that I think it's worth at least thinking about, especially if there's a known family history. So this is, again, obvious to this group, but this is sort of angioedema in the absence of urticaria. Although, as we pointed out, certainly once in a while patients will have hives, and that doesn't mean they couldn't have HAE, but it's really this pattern of recurring angioedema in the absence of histamine clues, itching, urticaria that we need to be testing for. And I've covered this, but C4s are easy to do, except if you try to get the emergency department to do them, they don't want to send that. If they can't see it in 2 or 3 hours, they want nothing to do with it. So that's one thing we've tried to get the ED to, I'll follow up on it, just put it in the system, I'll take responsibility for it. But otherwise, the C4 level, it's hard to screw it up. It's available at most hospitals and clinics, and it's good. It's not perfect, as I mentioned, but it's very good. And so this is a relatively inexpensive way to sort of get a clue whether this should be on your list of things to pursue. This is a bit of a busy table, and actually I don't love this algorithm, but I think it makes the point that if you see these patients with recurring angioedema, the first question, and this is what I do, is just as you pointed out, are they taking an ACE inhibitor? If they're taking an ACE inhibitor, it's that until proven otherwise, if you ask me. And actually, this is getting a little far afield, but there's very interesting data coming out now that people that have ACE-induced angioedema can have it recurring for a very long time after they stop the medication. I don't know, and I'm seeing more and more. I'm getting calls and I'm seeing referrals. I stopped my ACE inhibitor 2 years ago. I'm still having these episodes occurring, and they, in my hands, they don't respond to antihistamines. I mean, I think this is a bradykinin problem. Marco Ciccardi, who many of you will know him or the name, in Italy has been interested in this, and they've published now a series showing that they have people that are 8 or 10 years out from their ACE inhibitor and still having this pattern. C1 inhibitor is normal, you can't find anything wrong in their labs. So I think that's a rare subset, but I think it's a real phenomenon, and I don't know why. It's almost as if the ACE altered their metabolism somehow, to the point where now bradykinin has become an issue. So just be aware that I think that's a real phenomenon, and it's a difficult one to struggle with.
It's just in these cases, I think it brings out the tendency that there's a tendency there for whatever reason, and the ACE inhibitor just brings it out, sort of almost like a pseudo-allergen, but not quite.
So have you just sort of unmasked people with C1 esterase? That really was the point of your question earlier, if you unmask.
Yeah. So, and that's actually leads me to the next point. So one of the things I don't totally like about this is, so stop the ACE, does the angioedema resolve? Yes, well then I think you have your answer. If no, then I do agree with this. I think that's where you may want to look at a C4 level, because there are cases, it's unusual, of cases of unmasking a patient with C1 inhibitor deficiency who they just needed that extra boost, if you will, to push them into symptoms, but they do truly have HAE. So this is important, I think. If it's normal, then I still don't think you still may end up pointing to that. This says consider HAE with normal C1 inhibitor. Yeah, that's always on the list, but again, we have a really hard time establishing whether that's the true diagnosis or not right now. So, at any rate, if the C4 is low, then I think, of course, we're obligated to do the C1 inhibitor antigen and the function, and frankly, I just do both of those at the same time. Now, one thing I don't know that it's in this slide set, but I do want to point out for this audience, and you guys probably already know this, but there's 2 C1 inhibitor functional assays out there. There's what's called the Quidel assay, which is sort of an off-the-shelf ELISA kit. It's easy to do. It's relatively inexpensive for technicians to do. That's what LabCorp Quest, all the major national labs do. And the Quidel assay is good, but it does have a false normal rate associated with it. And this has been borne out in a European study, and we actually have a paper that just got accepted that'll be coming out in the next few months, also confirming that the Quidel assay does have some sensitivity issues with it. It's a small number, 5 to 10%, but it's sort of like the C4 level. It's not totally reliable. The other assay is the chromogenic assay. This is the one that's done in the rest of the world. If you go to Europe or South America, they generally do the chromogenic assay. And it's been shown to have a nearly 100% sensitivity for picking up C1 inhibitor deficiency. At the moment, the only place you can get the chromogenic assay is National Jewish in Denver. We're working to set that assay up at our place, so I hope to come back in a year and tell you can send it to us. Turns out it's really difficult to work with universities to get new lab tests added. Go figure. But we hope to have that because we do think it's a slightly better test. It's not, it's not apples and oranges, but it's slightly better. So the reason I tell you that is I think as specialists in this, if someone comes to you and their labs are not making sense and they got a really good story, you think for hereditary angioedema, at our place, we take the time to send it to National Jewish because we feel like we can absolutely trust those results. And so that's just a little pointer in terms of the diagnostics. And this is sort of the table you've probably seen a million times reviewing for boards and the like, but this just sort of lays out what you expect to see. The C1 inhibitor deficiency patients have low C4s and some abnormality in the C1 function. HAE with normal C1 inhibitor, that's the problem. It's normal across the board, so we don't have a good biomarker for that condition. Acquired, which is exceedingly rare, but we have a few of those patients. The dogma again is that the C1q is low. Now, be a little careful with that because the literature shows that about 25 to 30% of this population will have a normal C1q. It's not a perfect test. And my general rule of thumb, if I see somebody with severe angioedema showing up for the first time after the age of 40s, I worry a little bit about this. If it's antihistamine resistant, okay. Histaminergic angioedema is always going to be more common. I sort of should state that from the outset. But if they're not responding to antihistamines, they're over the age of 40, and this is the first time they've ever had symptoms. I worry about that. I mean, obviously you do the tests, and it'll tell you whether that's what's going on. And if you suspect this, I sort of hunt cancer until proven otherwise, because this is almost always lymphoproliferative disease that leads to consumption of C1 inhibitor protein. Sometimes you got to look really hard for it, and it may be of no consequence for a long time from a malignant standpoint, but it's there in the background often. We talked about ACE. Again, that's a clinical diagnosis. We don't have good lab tests at the moment to confirm that. And then this is, the bane of our existence in some ways, the idiopathic angioedema. I try to keep my sense of humor with patients. I tell them, that idiopathic, the doctor's an idiot, can't figure out what the problem is. They like that, I think, self-deprecating humor. So these are sort of obvious to this group, I think, but don't forget to test for HAE if you see this recurring angioedema, if you see airway involvement, and certainly if you see, I think unexplained abdominal pain is missed a lot. I sort of have had a little bit of trying to work with the GI docs to at least put this on their laundry list. Just send a C4 level if you see these people, but they almost always will have skin symptoms at some point along with that. What are we doing on time? Okay, in the last 10 minutes or so, let me say a few words about treatment. So the goal used to be to just keep these people alive. That's when we had supportive care. But now it's sort of shifted to actually trying to give them some normalcy to their life back. And this is where we think, everybody talks about quality of life, but I do think it's very important for these patients who if many times are disabled or certainly have their lives interrupted by these attacks. And we do think that specialist involvement is important, which includes all of you guys who are knowledgeable in this. So here's our treatment options. We can treat the attacks when they happen. We can prevent them by giving medicine in the long run to try to prevent the attacks. or we can use short-term prophylaxis prior to things like surgery or dental procedures. I actually asked them to revise this. We haven't revised it yet. I think this doesn't quite get it right, because I think every patient, so if you look at all the new consensus guidelines on HAE, and there's 5 of them now, everybody's an expert now that we have new medicines, everyone needs this. So this is sort of, to use an analogy, this is the EpiPen for the peanut allergy patient. This has to be, every HAE patient needs to have an on-demand treatment, because you cannot predict when a next attack is going to happen or how serious it's going to be. So I'll mention briefly, we have new tools.
Use that pointer.
Okay.
Outside audience.
Okay, yeah, sorry. They can't see me like they can. So we have these new tools in our toolbox to stop acute attacks. Historically, we only had, pain medicines, airway management, and in a pinch you could give FFP in the old days. This has never been really studied, though anecdotally it works. But we have good choices now, effective, safe choices to treat attacks. So everyone gets this. Now, in addition, some patients may get long-term prophylaxis. So it really should be, here's where we start, and then we add these 2 prophylactic options on as required, given the clinical scenario of the individual patient. And that's sort of what this is trying to get at. So if you know a patient has C1 inhibitor deficiency, HAE, we use the on-demand treatment during acute attacks. If it's not well controlled, then we look at triggers, which we'll talk about briefly, and then we consider long-term prophylaxis. I mentioned earlier prodromes. We don't understand prodromes very well. We know that half, or I would say the best studies show a little less than half of patients have reliable prodromes, and they're listed here. Some of these are very nonspecific, so irritability. I'm irritable all the time, but I don't get HAE attacks. So, but these are things that we have to be careful. I think in some patients they're very predictive of an impending attack. In others, I think they're not very predictive, and so none of the guidelines at the moment recommend strongly treating prodromal symptoms with these drugs that we have available. But they can be useful for patients who very reliably have them. So here's where the drugs work. I'll mention briefly these 3 agents that you're probably familiar with, but we have C1 inhibitor replacement products. We have a drug called ecallantide and a drug called icatibant. And so C1 inhibitor replacement works all the places we saw before during the flow chart on C1 inhibitor. Ecallantide is a very specific synthetic drug targeted at kallikrein, so it shuts off bradykinin production. And then icatibant's a bradykinin receptor antagonist, so it really stops the effect of bradykinin on that endothelial cell, keeps it from pulling apart and causing the vascular leakage. And I won't belabor this. This is in your handouts. You can sort of review. But just be aware, of course, there are differences in terms of dosing. So the C1 inhibitor products currently are IV. Ecallantide and icatibant are sub-Q. They have the different mechanisms of action, and of course they have different side effect profiles. So the C1 inhibitor products, 2 of them are plasma-derived. Here you only see Berinert listed as the acute option, Cinryze as the option for prophylactic treatment. These are plasma products that have been historically very safe, but they have the same theoretical concerns everyone has with blood products, so I tell all my patients about those before we start them. This drug just got approved by the FDA, Ruconest or Rucin. This is a recombinant C1 inhibitor protein. Has the same functional capacity, a shorter half-life, but it's actually produced in genetically modified rabbits. They actually milk the rabbits, which I've never witnessed. Someday maybe I'll see that. But they milk the rabbits, they purify the protein, and they give it to humans, and it's proven to be safe, except if you have a rabbit allergy. There's been 1 case of hypersensitivity in a woman who had a rabbit allergy, so don't give it to those patients. Ecallantide, as I mentioned, synthetic, inhibits plasma kallikrein. This has been a reasonably safe drug. It does have a black box warning for anaphylaxis, an anaphylaxis rate of about 3 to 4%. So that drug needs to be given by a healthcare provider and currently is not approved for self-administration. What's that?
2.5%.
2.5%? Yeah. Okay, so I round up to 3. That's okay. And And then icatibant is a bradykinin receptor antagonist, also sub-Q. This is approved for self-administration. It has been complicated by some injection site reactions and almost universally some pain at the injection site. So that's something we have to counsel patients about if they're going to use this medication. Yeah, Art.
Well, you know, that dose on Rucent was really large. 50
Yeah,
units per kilogram.
the approved dose is 50 units per kilo.
That's
So this is one of the differences between the plasma-derived and the recombinant is actually the dosing. Whether that translates to a clinical difference, I think, is hard to tell from the studies. The studies, as you know, are never designed exactly alike. It's one of the theoretical benefits. You can give more protein, might result in better response rates, but I can't say that that's true from the studies. And based on their platform, they can simply make more of this than, plasma supplies are limited and expensive.
So in Europe, even though it's a lot cheaper, you're using a lot more.
Yeah, I honestly can't speak to the cost factor. For the cost, at least in the States, hasn't been set to my knowledge for the recombinant product. But
And that was just what I was going to ask you.
Yeah.
I don't know if you're going to get into the price of these and if that is going to hopefully bring it down.
yeah, so it's a question we get all the time. These drugs are all expensive. I mean, there's no way around it. That's unfortunately the economics of orphan drug development. There aren't that many patients. Companies have spend a lot to get them approved. So these drugs are per dose. I don't know what Rucent's priced at yet. These other drugs are priced at usually $5,000 to $8,000 per dose. So they're very costly. And that's one of the hopes, quite honestly, because my hope would be that with more competition, you have more downward price pressure, and everyone has to sort of play ball with that. So, but I don't know if this company, where they're going to come in at.
I've always wondered, since C1 esterase replacement's new in the States, but not new in Europe, and still made by the Dutch Red Cross, I think, what this costs in Europe. They've had it for decades, and I don't think...
It's less expensive. I can't give you an exact number, but it's less expensive. And this is... I don't know much about the economics of pharmaceuticals.
We have this issue that for the product made in the U.S., it has to be made from U.S. blood.
Yes.
They ship U.S. blood to Europe, purify it, and ship it back.
That's exactly what one of the products does.
Yeah.
One of them has their own, facilities here. The other ships it across and ships it back. Yeah. So. Yes.
I know we talked this as an EpiPen for the HAE population, but what? It's not like the EpiPen that everybody will carry one, but also what's the expectation of hospitals, emergency rooms having these on demand? Should a patient?
Yeah, it's very difficult. So most hospitals, as you can imagine, don't have these drugs. In fact, most of them have never even heard of them. So I take a lot of calls from the emergency department from all over, and most of the time they've never heard of these medicines, much less have them. Because of that, in a known patient, my goal is to put the medicine in the hands of the patient, so they always have their own medicine. Now, with some of these, they either can't or shouldn't give it to themselves. So Calantide needs to be given by a healthcare provider. The C1 inhibitors are IV, which increasingly we're teaching people to do this, just like the hemophilia population. And they're quite capable, but it takes some time. So, but they should have their medicine. Then if they need to go to a doctor's office or an urgent care or a hospital, at least they can still get treated. It's just a matter of technically giving them and observing them for safety reasons. But to your point, that most hospitals aren't going to have this. So we've really worked to get patients have their own medicine so that they can be treated when they have attacks.
What are you supposed to use in little kids?
Yeah, kids are tough because, as you can see, none of these are approved. The lowest actually is a Calantide, although it's a little nebulous on the C1 inhibitor. It says adolescents, but certainly not children. The consensus, which has come largely from Europe based on experience, is the C1 inhibitor products are the preferred treatment for pediatrics. And that's not because we have rigorous controlled studies. It's simply because, as Dr. Altman said, these have been around for 20 to 30 years in Europe, so they've given the children a lot out of necessity, and there haven't been any major problems. So that's the preferred treatment.
Have you ever used the bradykinin and receptor antagonists in kids?
I have not, because at the moment, since it's only approved greater than 18. Now, to be honest, I've used it in a few teenagers, but no one younger than the age of, I think, 15 in my hands. And that's off-label. So, but there are studies going on with these drugs right now in the pediatric population to try to get at that, so that we can have better confidence that we're not causing a problem. But those are, of course, research protocols rather than clinical treatment. So, okay, let me try to move along in the last couple of minutes here. So we've talked about acute treatment. I think that's very important. Just a reminder, these don't work. You know that, but this is not a histamine problem. And none of the prophylactic treatments are perfect. So every patient, regardless of prophylaxis, needs to have acute treatment. I'm gonna not belabor all this study data with you. These are just the studies showing this is the plasma-derived C1 inhibitor showing that this works. The FDA reviewed this data and felt this was an effective treatment. This is a Callantide. Again, the scale is a little bit different. This is something called the mean symptom complex score, but a lower score here is better, or a bigger reduction is better. And so this again this is actually pediatric data, which was published by Andrew McGinnity. But suffice it to say that the FDA also felt this was effective for adults, not approved for small children yet. And this is the bradykinin receptor antagonist. I just like to point out, this shows the perils of clinical research. So you can see this first large study did not come out with a nice p-value. The second two did. And this had nothing to do with drug efficacy. You can see that's pretty consistent across the board, but the placebo group did really well in this one. This turns out to have been that they gave a lot of pain medicine for abdominal attacks in the placebo group, because we have to answer the IRB and we want to be ethical. But because they didn't censor the patients that got pain medicine, they looked pretty good. So then they statistically censored for that in these other studies, and it comes out better. So this was approved also. That was icatibant. Just a couple words on triggers. So we don't understand triggers well at all. As you well know, this used to be called angioneurotic edema, so this is a problem as far as emotional stress. But we do counsel patients on some of these other things: trauma, the menstrual cycle, infection. These can all be triggers for attacks. In the last minute, let me just say a word about prophylactic treatment. So we use this selectively in patients when either acute on-demand is not working well, they're having to access it quite a bit, or their life is just not back to what they need to do as far as accomplishing their goals. So there's no formula, there's no rigid criteria right now, not number of attacks, not severity of attacks. This is really honestly a judgment call between you and the patient as to whether long-term prophylaxis needs to be used. And so we do look, of course, at frequency and severity, but there's no hard and fast numbers for that. And so as far as options, we have the androgens, which have been used historically. We have a plasma-derived C1 inhibitor called Cinryze, which we can give IV every 3 to 4 days. And we do have antifibrinolytics, which historically in the U.S. haven't been used much, I think largely two reasons: due to efficacy data, which is less robust, and also the availability has not been good. But actually, Listata is now available again by prescription. So there are cases where have tried this when other prophylactic agents are not working well. You can actually prescribe tranexamic acid, and the Europeans love this drug. They've used it for a very long time, although the rigorous studies are not, the studies are not as rigorous as with the other two types of prophylaxis. So it's really basically selecting an agent. In children, again, we don't like to use androgens for obvious reasons. C1 inhibitor can be used and has been suggested to be a very good agent. But there is some experience with tranexamic acid, and I know, again, Mike Frank used this in his pediatric population for quite some time, felt it was quite successful. This is just to review data for you. This is androgens. Androgens do work, but they have quite a long list of adverse effects that make them difficult to tolerate for some patients, particularly women. And you can see the list of conditions where they're contraindicated. And this is simply the data from the pivotal trial of C1 inhibitor prophylaxis. You can see on average this did have about a 50% reduction, but it's not perfect. And there certainly were patients that still had many attacks, and a couple of patients that did poorly despite being on the C1 inhibitor replacement. So these are patients we're interested in studying further because there's obviously something different that we're not understanding about their pathophysiology. Let me just finally say that I think every patient with HAE needs to have a sort of action plan. We're used to this from managing asthma, but they need to have a plan. They need to know where their medicine is, how they're going to get it, and who's going to help them administer that medication. And we do use at our center sort of written action plans so that patients have this in front of them and know in a crisis situation exactly where they're supposed to be going and what they're supposed to be doing. So I'll just, I won't read off the summary slide. You have that. I think we're out of time. I do appreciate your attention, and I'm happy to take any questions you guys might have.
Before we launch into questions, actually, one thing I forgot to mention is you're claiming CME credit. The word of the day is La Jolla. It's a lovely place as well.
Not La Jolla.
Not La Jolla. And Lisa is going to present a complex case to follow, so any and all who can say either online or in the room will probably go on with about another half an hour. So Marc can get his claim as well. But I'll ask a question. And this may be contraindicated by current standards, but I still have a number of people, even women, on androgens, on danazol, and if the dose is low enough, it works, and most all of them tolerate it.
Yep.
And I've also used it for what I think is normal C1 esterase, and I think it works there as well. Of course, I have no diagnosis,
right,
but those are my impressions.
And I agree with you. I think that there still is a role for attenuated androgens in management. I think we just have to be careful with them, as you suggested. So generally the guidelines suggest keeping the dose low, certainly 200 milligrams of danazol or less per day, and the monitoring that goes into that. So liver function, cholesterol levels, which can, you get a high LDL, low LDL in many of these patients. That said, if those things are okay and they're not having, cosmetic side effects, which is really an issue for women more than men, I also have some patients that continue to use low-dose androgens, and I think that's the choice of many patients. Is this just easier to take that, and if they tolerate it, fine. So,
and I use it sort of as a diagnostic test that I'm correct that they have type 3, the old terminology. If I don't know what they have, but it abrogates their attacks, it changes the frequency dramatically, I assume that's the right diagnosis.
Yeah, and there is data looking at that. It's not, again, we're just starting to get, clinical data on the treatment of so-called type 3. It is effective for many of those patients. It doesn't look like it's as effective as it is for C1 inhibitor deficiency, but it will it will help many of those so-called type 3 patients. The other drug that actually is increasingly gained traction in that normal C1 inhibitor population is tranexamic acid. And that's actually where I've started to use it a bit more. I've had mixed results anecdotally, but the European literature is increasingly supportive of using tranexamic acid in the normal C1 inhibitor population. So I think one of those two options makes sense to try in that group. But, yeah.
How do you dose that? I don't have experience with that drug.
It's usually up to 3 to 4 grams per day, and so it comes in. I think it comes in a 660 for whatever reason milligram tablet. So I usually start people at 2 tabs in the morning and 2 in the evening, which comes out to about 2,500, 2.5 grams. And then you kind of have some wiggle room upward and downward in what's believed to be the therapeutic range. And it's usually fairly well tolerated. I've had a few people with GI upset, but most of the time they tolerate it well.
Other questions from the audience? David?
Did somebody ever check the ACE level in the blood?
In what patients?
In all of these, like baseline ACE level.
Yeah, so there have been some studies looking at that, and so far that doesn't appear to be the problem. Where there has been there's been a little bit of data now in the people that have factor 12 mutations. So again, drawing the circle around a very specific population. there's a European group in France that's looked at that, and they have started to show that there may be some defects in not in ACE specifically, but I think it was a different enzyme metabolizing bradykinin, but also in things that activate bradykinin and other enzymes that will lead to bradykinin production. So perhaps on both ends of the spectrum, a little bit of overactivation and a little bit of lack of degradation. Again, small study, and there's some methodological questions about how it was done, but people are thinking along the exact lines that you are. It's just probably not as simple as it just being ACE.
Marc, one person on the outside wanted your email address to contact you, maybe about referring a patient to the center.
Yeah, that's sure.
That?
Sure. It's my email is my first initial and last name, so it's MRIEDL at UCSD.edu. And we're happy to accept referrals, or even if you want to, chat quickly about a case sometime, that's fine.
All right, so Lisa, you know how to ramp up your slides. So let's let you get a refill on your coffee and present a case. No, you have your slides. Yeah. All right, Lisa, speak up so I can hear you.
I'm not sure. Yeah. So I'm going to just talk about briefly a case that I was involved in with a pediatric patient who's having recurrent angioedema attacks. This will just be kind of a brief narrative of his case. So this was a 5-year-old Hispanic male. He's actually 6 now. But when I met him, he was 5. And he had kind of a long-standing history of swelling episodes that first started when he was about 8 months of age. He'd had a fall, and his hand was starting to swell after that. His mom had seen several different people for this over the next couple of years, and she said he was having episodes about once every 1 to 2 months where he would have other episodes of swelling of his extremities, his legs, face, and was having abdominal attacks as well. I didn't state this specifically, but after listening to your overview, just to note, he did not have urticaria or any pruritus or those types of symptoms associated with these swelling episodes. And generally, they would last for a day, up to 3 days sometimes, and then just kind of spontaneously resolve. His other history, he had been otherwise healthy, didn't have issues in between episodes. Family history was pretty non-contributory in that the patient's parents, his brother and sister, were not affected with similar symptoms. I do know that his younger siblings had been tested specifically to see if they had any form of hereditary angioedema, but I don't know about the parents or his older siblings, just kind of piggybacking on some of the stuff you were talking about earlier. Interestingly, or maybe not surprising at all, different people had tried various things, such as antihistamines. This did not really help. He had, on several occasions, also been treated with prednisone. And at one point, he had been seen by an allergist in the community and was found to be dust mite sensitive and have asthma. And he was given an EpiPen for severe angioedema or anaphylaxis, but his mom had never tried that during any of his episodes. But not necessarily surprising, given where I think you guys can tell where this is going. This was not a form of angioedema that was histaminergic or responding to antihistamine, steroids, EpiPen, etc. So he got diagnosed a little bit later on, but of note at 2.5, he had a dental procedure under anesthesia, and at that point had developed pretty significant swelling of his lips and his tongue, which resulted in some airway compromise. He actually didn't seem to have laryngeal swelling or symptoms at that point. There was an anesthesiologist with him, and they just ended up monitoring closely for several hours until his symptoms resolved. He didn't get intubated at that point, but I think they put in like an oral airway or something to just kind of monitor things for him. And following that, he actually was referred to a dermatologist for these swelling episodes, and they were the ones who actually went ahead and did a lab evaluation for him.
Amazing.
Yeah. No, I mean,
Are there any
it's,
dermatologists?
No,
but,
maybe not mine, but.
and this was at our children's hospital. So, this spanned from 8 months to 3 years of age when he was finally evaluated properly. I think these are some of the lab values that were sent. So he had a CH50 sent, which was low.
Do you see that on your screen?
Oh, I'm sorry. No, I don't. Let me see if I can figure out how to get rid of that.
Click yes.
It doesn't show up on my screen though, actually.
I think it's from the projector.
No. It's really weird. I'm not sure how to do that. Maybe I can move it over.
Just real.
We'll work around it.
Okay. I'm sorry about that. It doesn't show up on my screen, so I'm not sure if it's being projected. Okay, well.
You left. You had to go to the clinic. So now we're on our own. Just get through it in the next 5 minutes and we're fine.
Okay.
You fixed it.
Oh, good.
Thank you.
Now get dismissed down.
Yeah.
Okay. All right. Thank you, David. All right. So, 1 second here. Okay. So, as I was saying, his labs that were sent, we see the CH50 is low, his C3 level was normal, but C4 was low, and he had both C1 inhibitor protein level and function sent, both of which were also low. So, based on this, he was diagnosed with HAE type 1. And as I mentioned, I finally saw him when he was about 5 years of age. At that point, he had come in. He was being followed actually at the Children's Hospital in our Immunology clinic because they weren't really happy with the care they were getting from their local allergist. And they had been told that it might be helpful because he was going for another dental procedure to come in and talk about getting short-term prophylactic dose of a C1 esterase inhibitor prior to that. So he came in, saw us. He got that dose. It was actually Berinert, which is approved for short-term prophylaxis. Even though he was only 5 at the time, our infusion center gave that to him, and he was able to go get his dental procedure done without any subsequent effects or ill side effects. So we continued to follow him on a fairly regular basis, and he saw us again in the spring of this year, actually, and was 5.5 at that point. And his mom said his swelling episodes were just increasing a lot in frequency. He was now having abdominal attacks about once a week or once every couple of weeks. She said generally his attacks would proceed with some kind of extremity swelling or other swelling, and then he would develop an abdominal attack a day or so later. And those would generally last up to a couple of days and were accompanied with severe abdominal pain, vomiting, diarrhea, to the point where he just wasn't able to go to school, and it seemed to be greatly affecting his quality of life. He also had recently started developing genital swelling episodes in addition to this. So the mother was just very concerned about how the frequency of his attacks had kind of changed a lot over the last year or so. So we discussed with him at that point what we could do in terms of a more long-term prophylaxis for him. As you discussed in your talk, there's not a whole lot that's been looked at for children of his age. So what we did was did a literature review, looked at some of the studies that were going on, and based on the publication by Dr. Lumry's group from 2013 that had looked at using a C1 inhibitor product in children 6 years of age and older. They even had a couple in the study that were in the 2 to 5 year age range. They looked at it both for treatment of acute attacks as well as for long-term prophylaxis. And they found that in the prophylaxis group, they actually ended up giving the product up to twice a week and were able to reduce the frequency of attacks pretty effectively in this pediatric population. So we kind of looked at what they had used in terms of dosing there, and the children in their group had been majority greater than 6 years, greater than 25 kilograms, and our child was pretty close to that age and fit in that weight category. So we used this publication to get our hospital to approve the use of a trial of weekly prophylaxis of him, for him, the C1 inhibitor product. And so he came in and got 1,000 units on a weekly basis for 4 weeks, and we actually saw that over that time period he did not have any attacks. So that was pretty in line with what they'd seen in this study. They said, I think the average attack rate for these children was about 3 attacks per month, median attack rate, and that decreased to about 0.4 per month after having a 4-week, twice weekly infusion.
And this was, you're just doing this once a week?
We did it once a week initially. And so at that end of that period, he was actually doing quite well. But then prior to the next week's infusion, he started to have symptoms.
Okay.
And then we saw over the next few months that every few weeks or so, he'd have kind of a breakthrough episode prior to getting his next infusion. So just this last month, they decided to increase him to getting twice weekly infusions. And after he came in for the weekly infusions, over that 4-week period, he was taught to infuse at home. So they do it at home now. We also, another interesting point you mentioned about the availability of these medications in hospitals. So we had contacted his local emergency department to try and get Barrier on formulary for him, just so that they'd have that available in case he had episodes. And so they're pretty familiar with him now for the last several months. So I think that's pretty much all I have. I just wanted to highlight that as I thought it was an interesting pediatric case. And clearly there's more that needs to be done to get an FDA-approved treatment for children in this population. I don't know how common it is to have kids with that severity of disease at this age, but...
Yeah, so a couple things I would highlight. We have a couple minutes, right?
Sure.
Can you go back to the lab page, the lab slide? So this is a great teaching point because I do get a lot of referrals for people that have a borderline C4 or a borderline C1 inhibitor level, and those people usually don't have C1 inhibitor deficiency. So this is the real deal, I guess, is what I'm saying. So for reasons we don't really understand, usually the C1 inhibitor protein level or function is far less than 50%. And mainly it's the level. So people have said, well, you have one good gene and one bad gene. The protein level should be about 50%, right? It's not true most of the time. Usually it's 30% or less of the normal level. And so it's not clear if there's increased metabolism. There's been a little bit of data that for whatever reason the good gene gets down-regulated sometimes by mechanisms that aren't clear. But at any rate, this is profoundly low, and this is what we typically will see at least at the protein level and the C4 level. The other thing I was going to mention is that we've historically been very bad at predicting severity based on labs, meaning that no lab will predict how severe a patient is going to be as far as a phenotype. There's one study now that shows that the function predicts severity, generally speaking, that there's a strong trend. The lower the function, the more severe symptoms you have. And he's got a very low function, 14%. So if you believe that study, which hasn't been replicated in another population, but he's in for a rocky course, which it is a little unusual to see this severity in this young of a child. It happens, but it's sort of milder and then gets worse as they hit their teenage years. So that's sort of interesting. The other thing I was going to say, and the reason I asked about the once a week, so as you guys know, the FDA approves C1 inhibitor prophylaxis at 1,000 units every 3 to 4 days. This is, of course, mostly in adults, not kids. But it's pretty clear to most of us that it's not one size fits all. And so I don't know if you have people on this treatment, but what we see in the real world and what's actually been published now in a couple studies is that it's sort of titrate to effect. This is all off-label stuff, which is what we do in the real world. But what we're finding is that some people need more than 1,000 units twice a week, and John Bernstein has published a paper now showing that it appears to be safe, at least in a small group, to titrate up to as high as 2,500 units twice a week, and that you do make some people better when you do that, so they just need more. But on the other end, sort of like your little guy, Bruce has published open label. Now, it's open label data, but showing that if you take that 1,000 unit twice a week and they start to spread out their dosing, that a lot of them can get out to once a week dosing and still have the same effect in terms of preventing attacks. Beyond once a week, you start to have trouble. People start to break through a lot more. But so I'm not telling you things you don't know, but there's a lot of variability, and so depending on his course, he might be able to get away with once a week. Sounds like he had to go to twice a week.
At
but
least we're giving that a try now.
Yeah, so we do, we don't change it up that quickly, but over time we sort of titrate up and down. Less medicine may be better. We don't know if in terms of safety, but just like asthma or anything else, you kind of titrate to clinical effect. So I think that's interesting that at least initially that worked, the less dosing.
And I don't have a lot of experience with this, obviously, but in terms of long-term prophylaxis, especially in a child of this age, I'm not really sure what to tell them in terms of the future, and is this something he's going to need to be on this dose long term for how long? I don't know.
Yeah, and I don't think there's, you kind of have to see how it goes. As the variability, some patients ride the roller coaster, I call it. They can have really good times and really bad times, and you sort of have to be flexible in the treatment plan. In the long run, the biggest issue we've run up against now, because the C1 inhibitor prophylaxis has been around since 2008, so we're running on 6 years. But the biggest problem, not surprisingly, has been IV access. So I'll go on record. I'm not a fan of ports unless they're absolutely necessary, because it appears, at least from the little bit of data out there, that the risk of thrombosis with C1 inhibitor products, which has been a concern, increases when you put a port in. Most of the big thrombotic events have been related to people having ports placed. So we try to use peripheral access as long as we possibly can. So you get into things like vein care, which I'm not an expert in, but the hemophilia centers have been doing this for a long time. So that's the biggest issue in the long run, is how long can you continue to do this twice a week before you run out of spots that are going to work. The good news is that we're working on new ways to do this. So sub-Q C1 inhibitor is in studies right now. If that works, it'll kind of be like immunoglobulin. I think it'll make life easier for a lot of patients and easier for them to do. And then there's a couple other agents in the pipeline. There's an oral kallikrein inhibitor for prevention, and there's a monoclonal antibody against kallikrein that might be given, once a month potentially. So these would be different ways to accomplish the same goal, so that people might not have to be doing these infusions for their whole life. But I don't know whether any of that stuff will work. It's all in clinical trials right now. But
how the Europeans been handling this for all these years,
So they have sort of the model that's emerged there predominantly, depending on what country you go to, is what they call IRT, Individualized Replacement Therapy. That's sort of a hybrid between acute treatment and prophylactic treatment. And it basically means they give the medicine to the patients, they teach them how to use it, and then the patients kind of decide to do what they're going to do. And a lot of them will sort of either gravitate to, once a week or however, the least amount they can, use it prophylactically. Or some of them get very good at treating prodromes. So they realize, I feel like I'm having an attack, I'm going to infuse. And so it's not usually as frequent as twice a week, but it might be a few times a month. So they've actually put a lot of this in the hands of their patients to sort of figure out what's going to work best for them, which does make sense, I think, as long as they're safe with it. So, our insurance companies don't allow us to do that, although, we sort of do that on the sly sometimes with things. But anyway, that's been their answer over years, is the kind of a hybrid model. They understand our sort of paradigm, prevention versus acute, but they've kind of blurred the line over time. So,
Two minor comments. It's interesting. I never measure a CH50. I guess it shows that a dermatologist is managing the case. But it makes sense that it would be low if you have no C4. You can't really have an effective total CH50. The other irony that this reminds me of, as you pointed out, this is a pediatric disease, and here we have these products and we don't have pediatric indications for their use.
And the one we have is the IV one, which is, it's hard to get kids to sit still for that sort of thing. So.
This done reasonably well with that.
It's kids that are affected by this are tough. You don't have a lot of options.
So Lisa, usually when you present a case to a visiting professor, there's an unknown or a question or something that you
It's a little
lead
hard
up to.
to map the,
Have a question?
Well, I think my main question was just kind of, the course going forward. We kind of discussed that in terms of, how severity can be more of an individual and variable thing. So.
And you have a question?
I do. On this very patient. So he's been on the 2,000 units, the 1,000 twice a week, and he's still breaking through.
Oh, really?
Like, I got a panic call from the mom about 2 weeks ago about an emergency department for this. That's why I was asking about the fears here and other options. What do we do next? Like, if he's still 2,000 units at Sunrises, it's a lot for a little guy like this.
So again, you sort of get into uncharted territory pretty quickly, but that it is what it is. My own view would be based on what I know, the safety data that's out there. I would still probably try to updose the Cinrise. Go to 1500 twice a week and see if that helps. Again, in kids, you're right. We don't have the studies that have been done on updosing have been in adults. So, but his level is pretty darn low. So I don't think you have to worry too much about overshooting and getting too much C1 inhibitor. I would do that before I would add something else in. Frankly, and again, I'm not a pediatrician, so you guys are braver sometimes than I am. But I just worry about giving drugs that we have very little safety experience. I'm sure icatibant or icalantide are likely to work. I don't know what the possible side effects could be in a little guy like that.
I still have a clinical trial that's going on right now. Down to 2.
So that's an option. I mean, they could enroll in a study. I don't know if there's a site around here, but that's one way to do it. And then the other would be, adding in, like Mike Frank used to, adding in like tranexamic acid. I wouldn't do androgens in kids, obviously, but tranexamic acid, there is some track record for pediatric use, but you just have to sit down and make sure you're monitoring everything closely. So that would be, those would be my next moves personally.
Any other questions? Yeah, Sydney?
I actually have an adult patient who we've been, apparently for whatever reason, danazol wasn't approved by his insurance for prophylaxis, and he gets pretty frequent attacks, and he lives in a rural community. So what's your experience with efficacy? We're going to go to tranexamic acid next. Between the androgens and the tranexamic acid in terms of prophylaxis.
The data suggests that the androgens are more effective. The data on tranexamic acid suggests that it helps about 70% of patients. It will improve their control, but only about 30 to 40% will that be substantial, meaning above a 50% reduction. So I think tranexamic acid in the C1 inhibitor deficient population is clearly inferior in terms of efficacy. So I think androgens are more effective. The side effect profile is probably more tolerable for tranexamic acid, so that's the trade-off, I think, depending on your patient's preference and your preference. But the discussion I have with patients with true C1 inhibitor deficiency usually centers on androgens or C1 inhibitor replacement. And then as a secondary, if they really don't like those options, well, there is tranexamic acid. In women, there is some data that progestins will help a certain subset of them, so you can put them on a progestin-only contraceptive. But the data there is also kind of flimsy right now. So I think, danazol or C1 inhibitor, second line would be tranexamic acid or progestin in a woman if you can't, for some reason, don't like those or they don't tolerate the others. And that's mostly based on efficacy data we have.
Do you combine them together?
You can. We don't do it a lot, but yeah, I have a few patients on low-dose androgen plus C1 inhibitor. I mean, those are the really severe ones that need more than one agent. But my preference is always to try to max out one before you add in another drug, but sometimes you need them. The only just one last thing, the only combo there that I wouldn't do is tranexamic acid and progestin because of the thrombosis risk, theoretically. So if they're going to do, and again, I don't have a lot of patients on those, but if they're going to do those, you got to choose one or the other. We don't combine those two. Yep.
You mentioned this kid is pretty severe. Have you noted severity with life-threatening laryngeal stuff? Is that more likely to happen in somebody with extremely low levels?
Not in my experience. Yeah, the only thing that's been traced to, and again, it's one study at one site, but was in terms of frequency of attacks and then the actual severity, on a scale of the attacks, not anatomical location. So that remains sort of, I think, unpredictable. Yeah.
Which organ makes the C1 inhibitor? Is it in the liver mostly?
I'm sorry?
Where is it being produced?
Yeah, mostly hepatocytes. Monocytes make some, but mostly hepatocytes.
So you can't transplant them. Very severe.
Well, so it's interesting. There is a case of I'm trying to remember the condition. There was a liver transplant for a completely different reason in a patient that C1 inhibitor deficiency, and it did cure them.
It's been said that androgens upregulate C4 production. I've always wondered if that's truly the mechanism?
C1 inhibitor production.
That's right, the C1 inhibitor.
That's one, never been definitively proven. That may be part of it. There's some data now to show that the androgens probably also increase bradykinin metabolism. So again, androgens may work on both ends, decreasing the production of bradykinin through C1 inhibitor stimulation, but also breaking down bradykinin faster. So we've never really known why androgens work.
Yeah, Mike Frank's original paper, it's interesting to read how he stumbled on this. But the success rate, is better than any of the new agents.
And he had what I like about his paper, brilliant study design. He proved the clear efficacy of this with like 8 patients. Which you could never do today, but he had this brilliant design where it was, symptom-free periods, and the people on androgens went the whole period, and then they crossed over and they'd have an attack. And anyway, it's a nice paper.
Well, thanks for taking the time to come up here. I'm glad you guys have a center for us to refer.
Yes.
I know I have some people that I just tear my hair out. I don't know if they're Munchausen or what is wrong.
Yeah, I do. I'm a big fan of pictures, photos.
Yeah,
if people can't produce photos, I get suspicious.
That's what I say to people. Do you just feel swollen, or do you look disfigured that any stranger would know you look weird?
Yeah. No, I think you have to ask those questions. Thanks for the case. Yeah, I would, I think you mentioned it, but I don't know if there's slides. I'd be clear that there was no hives, there was no itching, there was no allergy-like symptoms, because that's where I think most people get off, is they don't, if you're having angioedema, it's histamine, like they don't